Hi guys, welcome. We are super excited to have you here. We are going to be talking about all the fun things today, starting with levels of care. So first of all, I just wanted to say thank you so much for being here. My name is Dr.Kasi Howard, and this is truly one of my favorite things to get to do. I love to talk. You can ask anybody in my family. And so I really love being able to share with you guys and just being able to meet new people. Kind of different since we don't really get to talk, but I would love the interaction. It's always really strange for me. I like to make jokes, and whether they're funny or not, it's the nice thing about being in a room of actual people is you get feedback. And so please feel free to go ahead and throw up a hand, do little emojis, do, laughy faces, do something to try to make me feel better and a little bit less alone out here. I am going to, I see that hand, Travis. See, I love it. I am pulling up the chat box here, so I'm going to try to pay attention to it. Sometimes I get distracted, so I want to be the best keeping up with it. But if you have a question in the middle of it, please throw it out and I will definitely try to get to it. And we're going to try to make this a little bit more interactive. So thank you so much for being here. So one of the reasons I really want to do this presentation is I started ANOVA about 6 years ago as an IOP. And at the time that I started it, I would go out and I would talk to counselors, and I realized that a lot of people really didn't know what IOP was. And they really weren't familiar with the various levels of care and when to refer out, when to refer up, and kind of what your options are for being able to offer different things to your clients. So I think that it's really important that we understand what all the treatment options are so that our clients can get the best possible care. So, and we're going to do this in the most ethical way today, so that you can get some good ethics credits for this. And yes, where the points don't matter. Try to throw in some fun little memes for you guys here too. Okay, so we're going to start in just kind of some basics, really reflecting on what would be considered the proper continuum of care. So before we ever get to anything, we would hope for some early intervention. We would hope that people are maybe, practicing self-care, reading a book, listening to a podcast, talking to a friend, a pastor, something like that in the very beginning for early intervention. Then the next level up in an ideal world would be outpatient services. So you're going once a week, and we're going to talk a lot more about what each of these levels of care are and kind of what that looks like. But then after outpatient, and I always just describe that as your once a week, go sit on a couch for an hour and talk about your mother, right? You guys know what that is. Then we get to intensive outpatient and then partial, and then we go to residential, which most people think of as rehab, but you can actually find residential for just about anything. And there's even different levels of intensity of residential services. So you can go all the way from a really, kind of loose, free environment to a very highly structured, like locked environment. And then you have intense inpatient services that are medically managed. Typically, when you talk about inpatient, then that means a hospital. And a lot of people don't know that. Even for our residential program, people will say, oh, I need inpatient, and they don't. What they need is residential. But it's just not a term that people are really familiar with for the general public. So typically inpatient is going to be like in a hospital, very highly structured and not necessarily therapeutic. So this is kind of the continuum of care outline that we're going to be talking about today. So something very interesting, we use the APA for a lot of things for our guidelines, and there's amazingly not a lot of formal structured guidelines out there for mental health levels of care. There's some that are specific to eating disorders. There are some that are specific to substance use. But when we talk about mental health, then you're kind of piecing things together a little bit more. But ASAM does have very specific criteria for substance use. So anytime you're dealing with somebody with substance use, then I want to strongly encourage you, really go to the ASAM website. They have very structured interviews you can do that spit out exactly what level of care they need to be at. They don't play around with this stuff. So, in the very most extreme, you're going to be needing detox or withdrawal kind of thing. You're looking at different sorts of medical complications. Once we move on to dimension 3, then you're looking more at the emotional, psychological kind of complications. So that would be more like a residential, a quote unquote rehab. As we move on to dimension 4, then we're looking at probably like an IOP, somebody that's really ready and willing and wanting to change. And then dimension 5 would be closer to like an outpatient. So where they're just really exploring what's moving on, and then a recovery living environment, where people are living it out. And they just need support to be able to do that. So that's kind of what it looks like for substance use. Now, when we're evaluating criteria for levels of care for adults and for teens, we're going to be looking at 7 different dimensions. The first one is risk of harm. So this is, are you suicidal? Are you a harm to yourself? Are you a harm to somebody else? And kind of tied in with that can be your functionality status. So someone could be not necessarily suicidal, but they might not be functioning very well. And it could be in such a way that is actually harmful for themselves, right? So this is where maybe they're not eating enough, maybe they're overeating, maybe they're eating the wrong things. It still could be harmful for them, right? Or like they're not bathing, they're not taking their medications. That would be a big functional one that could actually cause harm. So that's what we're going to be looking at there. Next, we want to look at comorbidity. So this is really important. So somebody that has pure anxiety may be, hanging out in their house. They may be fairly low functioning in that regard, but they're going to be in a different, it's going to look very different than if they have really high anxiety and they have a strong history of trauma, so some PTSD that's causing the anxiety, and maybe they have schizophrenia as well, or maybe they're also bipolar, or maybe they're also using substances. So comorbidity is extremely important to look at. The level of stress and support in the environment is very important. And so somebody that may be in a vacuum could be higher functioning, but they are in a very non-supportive environment, is going to probably need a higher level of care than somebody who is in a very supportive, loving environment that's going to make sure they shower, make sure they take their meds, make sure they get out of bed, take them out of the house, all of that sort of thing. Willingness to engage makes a huge difference. So someone that is very motivated to work on things versus somebody that, is not, is going to make a huge difference as well. If they're really just kind of hopeless about it, they don't think that they can change. They don't want to change. Unfortunately, a lot of times, especially with our PTSD clients, we see that anxiety really makes people feel safe. So they may not really want to change in those moments. And then different social determinants of health. And so are they engaging with other people? Are they, what are their external, in the old days of DSM 4, we would say their axis 4 kinds of issues. What does that look like? And then for children, we're really looking at a lot of the same things, the same factors, but we're looking at it in a much more age appropriate environment. So what does it look like for them at their age and what they're willing and able to do for their age? And then the most important thing with kids, you are evaluating the parents or the caregivers just as much as you're evaluating the children. And so do they have, again, very supportive, loving parents that, the center I used to work at, for example, we could have somebody that we would say we were a partial hospitalization clinic. And if somebody needed what we would call arm's length, right? So that one-to-one monitoring, we could maybe avoid sending a teenager to the hospital if their parents were willing to go do a thorough search of their room, take out all the paper clips, all the knives, all the things that they could self-harm with. If their parents, it would get pretty extreme. We would say, hey, they need to sleep on your floor tonight. They really aren't safe to be in their room alone at night. And if parents were willing and able to do that, then that person might be okay in a lower level of care than somebody whose parents and caregivers are really in a lot of denial, or they just don't personally have the internal resources or the physical resources to be able to deal with it. You might have a single parent home where the parent works nights. And so that kid may need a higher level of care than if that exact same kid with the exact same symptoms were in a two-parent home with one parent that stays at home. Makes sense. So, we are going to start out and talk about, we're going to go from most extreme to least extreme on the levels of care. So inpatient, kind of general criteria if someone was going to an inpatient hospital. So here in San Antonio, that might be like some of our hospitals, like a Methodist hospital has a psych unit. We have psych hospitals. We have two here in town that can take people kind of like on a walk-in basis for acute hospitalization. So, excuse me. We're looking at their heart rate might be extremely off. They might have refusal to eat or significant weight loss. Maybe they're just so depressed they literally can't like even bathe or eat on their own. Like their ADLs are just trash, basically. And they might have other psychiatric disorders. So they might be having a psychotic episode where, they think somebody's chasing them or something like that. They're hearing voices. We definitely want to make sure that we're keeping them safe at that point. They could have suicidal thoughts and they can have with or without intent. So a lot of times as therapists, we really want to focus pretty heavily on the intent, which is important. But you don't know if someone has, if they have some pretty lethal suicidal thoughts with a plan, even if they say, no, I'm not going to do it. You really want to evaluate these other factors because intent can change very quickly, right? Anybody ever make a New Year's resolution? Intent can change very, very quickly. You intend to do one thing and you end up doing something completely different in the moment. So we want to make sure that we're keeping people safe, kind of regardless of their intent, if they have high lethality. Now, there is another situation where we have like passive SI, and that's just this like, oh my gosh, like I don't want to be here. I don't want to do this anymore. It's a very different type of thing, right? So we want to make sure that we're carefully evaluating between the two. Typically, someone who is in this level of care, they may just like lack the motivation. And if they don't lack the motivation, then they probably lack the resources to be able to follow through with their motivation to make things better. And they may have an incoherent thought process. And so they may be, they're just not making sense. They're kind of all over the place. And that can happen not only with like serious mental illness or SMI, that can happen if they're just simply like really depressed, right? Or they're extremely anxious. Like it's so much that amygdala, that emotional brain has just taken over and their frontal lobe is just not able to communicate all the things that it needs to. Next up is residential treatment. So in residential treatment, then you still need a very high level of structure and supervision. As I said, residential treatment is typically what people think of with quote unquote rehab. But you can actually have residential treatment. We have a residential treatment center for PTSD. There's residential treatment for eating disorders. So there is residential treatment for other things that is not necessarily substance use related. So these people still need a very high level of structure and supervision. They still need prevention of self-harm and suicide. So I think this is a common misnomer that if someone is suicidal, they automatically have to go to acute inpatient. They don't. Residential can most residentials can absolutely handle someone that has self-harm, suicidal thoughts. But we just need to make sure that it's to the point that maybe they're willing to contract for safety. They have to have a little bit of motivation. If you have somebody that is just wanting to jump out any window that they see, then a residential is probably not going to be able to keep them safe enough. But if they are able to at least acknowledge those thoughts and want to process them, then residential may be the perfect level of care. Someone who needs residential needs help managing just really extreme symptoms of anxiety, depression, mood swings. They are not safe staying at home. So this might be because, again, of self-harm urges or suicidal thoughts. It might be just because they're not really able to live life and take care of themselves in a safe way while at home. But for whatever reason, home is not a good place for them in that moment. They really need some pretty intense, focused work to address symptoms. Somebody who needs residential treatment is probably not keeping a great schedule. So it's always really interesting to me whenever, I've approached the topic with clients before of, hey, you really need to go to residential treatment. I think that, I think you could use to go away for 30 days. Most residentials are around 30 to 60 days, most around 30. And you should really go somewhere and kind of work on this intensely. And they'll say, no, what about my job? And I'm like, sis, when's the last time you've been to work? Like, you have been late to work for the past 2 weeks and you haven't even gone for the past 3 days. And so tell me more about how you can't take off work. Like, you're probably going to lose your job. So we need to kind of help people be realistic about what they're actually doing versus what their intent or their goal or what they're required to do. Impaired ADLs, that goes back to the not really showering, not cleaning the house. I think that's something that we don't typically ask people about in an intake. That is a really important question. So how often are you brushing your teeth? And how often are you cleaning your house? What does your house look like right now? When is the last time you did dishes? And if somebody says, oh my gosh, it's been 2 weeks, then we know that there's probably a deeper problem. A lot of times in residential treatment, somebody may need a safe place to do what we call the work. I have a client who used to do the little trademark thing next to the work. And I'm just not smart enough to get a trademark point on a PowerPoint slide. So whatever, dreams. Anyway, so sometimes I've had clients that, especially when we're talking about trauma work, if they need EMDR, they need something like that, they know that they're just not safe to go home after they do an EMDR session. They know that trauma work is hard and it's going to stir up so many things for them that they're barely kind of holding it together, but they are. But if they were going to start digging into the trauma, then they would probably need to go somewhere else to be able to do it. That is residential is then the perfect place for these individuals because it's not as restrictive as an inpatient, but it has a lot of support 24 hours. These clients may really struggle with motivation. They may or may not want to do the work. A lot of times I think they have a faint idea that they do, but they just don't have the resources, the internal resources in the moment to really be able to work on things. And of course, they may be totally isolated. Typically, by the time somebody gets to residential treatment, I've seen one girl that was going to residential and she still had a bunch of friends and they threw her a huge party before she left. She was going to eating disorder treatment and everybody wore little glitter crowns and all of those things. Everyone else I've ever seen go to residential, they're they've kind of isolated. They don't have a ton of support in the moment. So if we are talking, just to kind of give you an example, I think that seeing, because we can learn about things in books, right? And we can look at levels of care, but like, okay, what does this look like if a client is sitting in my office? What are they saying? And how do I know that this is the level of care that they need? So if someone needed residential for PTSD, they might be having nightmares almost nightly. So their sleep is impacted all the time, right? And if you can just think, I think it's sometimes we hear things and we go, oh yeah, that sounds horrible. Think about having nightmares every single night. Think about when you wake up from a nightmare, how it kind of sits with you, and maybe you have a hard time getting back to sleep and your heart's kind of racing. And if that's happening every single night, you're probably truly exhausted. Your body is exhausted. Your mind is exhausted. That alone can be a very big deal. So it's really important, I think, when a client says they're having nightmares, to assess how often that's happening. How often are they avoiding social situations? So are they typically, I think a lot of people are just they would used to be where they would go to work and then just come straight home. Now, in this day and age, a lot of people work from home, which sounds great. But if you were already avoidant and you're already super anxious and now you're just staying home all the time, then what you've probably done is just make your avoidance a whole lot worse. So we definitely want to be able to, look at how are they interacting socially? Are they able to go to work? Are they struggling to get up and to do the things they're supposed to do? They're probably, like I said, like they've missed the last, 4 days of work, and out of the past 2 weeks, they've missed 5 days of work. Trouble maintaining social relationships. They're just pushing that. I always tell my friends, like, you right buttoned me, right? So they're pushing that right button on the phone when it rings. And maybe the phone has even stopped ringing if they've been doing it for a while. They're having flashbacks a couple times a week. They might be coping using substance use or promiscuity, or isolation, any of that. Intense fear leaving home. So one of the first things I hear people say is like, I don't go to the grocery store. And it really is such a catch-22, the world that we live in now, because you can work from home, you can have your groceries delivered, you can have your Grubhub delivered. You can truly go weeks without ever having to leave home, which can be really problematic for somebody who is already kind of suffering and struggling. So it's definitely something, if you have a client who I would say is experiencing 3 or more of these, then you probably want to look at a higher level of care. So let's look at Susie Q here. Susie comes to her session and her speech is really scattered, and she looks somewhat disheveled. She shares that she drank a bottle of wine to try to get to sleep last night. She's been having nightmares regularly. She called into work today. So that's that work piece that we were just talking about. She spent most of the weekend in bed or isolating. And she says that she's tired and she doesn't know how she's going to keep doing this. She's pushed away most of her friends and she doesn't have a great social network. So if Susie is my client, then when she comes in, then I'm going to say, I think you need a higher level of care. And one of the things I want to jump in right here with kind of a commercial break intermission and say is that I think sometimes as clinicians, we think it's our job to be able to handle our clients' symptoms in whatever format they present and, however they show up, that like, this is what we're supposed to do. And it's not. Like it is our job to make sure that they get all of the care that they need. And there have been times where I've had to make the very hard choice with a client to say, you need a higher level of care. We're talking about it. You're not motivated. You're not going. And if you continue to just see me outpatient, then you're going to tell yourself that you're in therapy and you're doing something about it, but you're not doing the right thing, right? It would be if you're training for if you tell yourself that you're training for a marathon and you're walking half a mile a day, you're not actually training for a marathon, right? So it's just not enough. It's something, but it's just not enough. And it's not going to get you there, and it's not going to help you meet your goals, right? It's not going to get you across that finish line. So if you have a client that's just continuing to struggle, or they're really, that they're more than what you are able to like really see progress going up with, then they need a higher level of care. And there's no shame in that for you. That's just you being a good clinician. So PHP is probably one of my favorite levels of care, and probably one of the least common. So for people in PHP, they need structure during the day, but they probably have a positive home environment, or at least not a super negative home environment. So they are able to kind of make the best of it. They're able to keep themselves safe. They're able to get up for programming. That's a big one, right? So we've had people that we've tried to put in PHP, and programming starts at 9 a.m. and they roll in at 10:30 every day. And we're going, I think it's not working, right? Like, you got to be able to get up and get here. And if you were doing that in a job, you probably wouldn't have a job anymore. So do you need more care? So it's people that need structure during the day. Again, they probably still have some impaired ADLs. For someone who needs, typically PHP is 6 all the way up to 11 hours a day. Most commonly, I think like 7 to 8 is a PHP time, and it's at least 5 days a week, and it can go up to 7 days a week. And so if you have somebody that's needing really intensive care like that, then they're probably not doing all the things of life, right? They are still having intense symptoms that inhibit daily life. They can be safe at night, but they can manage a schedule like we talked about. And going home isn't going to undo the work that they did during the day. So let's talk about Katie. Katie experienced horrible abuse as a child. She's never truly dealt with it, but instead she left home and she just kept going. She now has a really supportive spouse and they want to have kids. So she recently found out, that another cousin was also abused by the same family member. This has really been triggering for her. So now she's just staying home all day and she's not leaving the house without her husband. She feels really hopeless. Her sleep is broken. She really came to you. She wants to do trauma work, but she's worried about going home after her appointments. So Katie is one that we would say would be a great candidate for some PHP, where she can go get some really focused treatment. Home is a good thing for her. She's got this great husband. So we don't really necessarily want to take her away from that. We want to take advantage of the resources that she does have and maximize those. So we want her to go home and be able to, relax with him at night. But we want to make sure we get her more help during the day. So that's Miss Katie. And yes, it is, PHP just doesn't happen as often. I think sometimes people don't do the early intervention needed, and people don't have the supportive home lives is really what it comes down to. Like, a lot of people, if they're struggling that much, they probably don't have a whole lot of greatness going on at home. Not always, but sometimes. IOP, intensive outpatient therapy. Now, IOP can be for a variety of different reasons. And one of the things I love about IOP is you can almost look at it like if you were going to go on a yoga retreat kind of thing, is how, or like a boot camp, like if you were going to take a really intensive kind of class, then you're doing, IOP is typically 3 hours a day, 3 days a week. So it's about 9 hours a week of group therapy. And you are just getting all the skills. So it can be a great level of care for somebody, even for a brief amount of time, who just says, you know what, man, I want to bust this out. I want to do the work. I want to learn the things. I'm not playing around. So somebody can actually be super high functioning and be an IOP and just be very motivated to want to work on their junk. Or they can be somebody that has difficulty keeping a schedule. They're still struggling to maintain relationships. They need some structure. they can definitively contract for safety and remain safe. And so if someone is in IOP, then we're not super worried about that they're going to hurt themselves. That's one of the things when I first started Inova as a virtual IOP, before the world went virtual, before we were doing all this before it was all cool, then people would say, how do you know people are safe? Well, it all comes down to keeping them the right level of care. So if you had an in-person IOP that people were coming to, they're still leaving your building after 3 hours and they're going home. And how do you know that they're safe at that point, right? You have to make sure that you're doing a right level of care assessment and that that you can know that they're safe and they're in the right level of care. They are pretty motivated. They can maintain their ADLs. They can maintain a schedule. People in IOP are often working and or going to school, but not always, but sometimes. A lot of times they still don't have a ton of social supports. If a client comes to you and they're really struggling in between sessions, to me, that's a really good sign that they probably need more. So if every time they come in, they're in crisis and you're not able, you have your treatment plan, you have your goal sheets that we want to address this maladaptive behavior, we want to look at this trauma, we want to do this. And man, we can never get to this because every time you walk in, we're talking about the crisis of the week and what that looks like. That person needs IOP. And it will make your life as a therapist so much easier. While people are in IOP, they're still seeing their outpatient therapist. So if it's a client that you have a really good connection with and you're making some progress with, you just wish you could clone yourself, send them to IOP and let them keep seeing you while they're getting some extra support and learning extra skills, kind of at like a warp speed, right? Like our IOP, one of the groups we have is DBT. So if you think that while someone's seeing you, then they're also learning DBT a couple days a week, they're working on shame issues, they're addressing sleep issues, then you're going to make progress so much faster, right? Love IOP. So real world scenario, if someone has a history of PTSD or trauma, and they come to you and they're missing work and school, sometimes, not always, but sometimes because they need a mental health day. If they're using negative coping behaviors, so they're being promiscuous, they're drinking a bottle of wine every night. If they're having a lot of nightmares, difficulty sleeping, they're having a hard time setting boundaries. Relationship issues is a big one. So this is where we talked about how somebody could actually be pretty high functioning and be a great candidate for IOP because they're able to do work or school, they can do the things, but they're just not doing life really well when it comes to other people and coping. That person is perfect for IOP. So let's talk about Miss Jill. Jill has a job. She goes to school part-time. She's thinking about dropping out because she's having a real hard time concentrating. She has nightmares a few times a week. She has a few close friends, but they're friends that she's known since high school. She hasn't really made a lot of new friends because she doesn't trust people. She doesn't want to have sex with her husband, although he is supportive and he wants her to have help. And she doesn't understand why her childhood trauma is suddenly an issue when she has been fine all this time. Anybody ever hear that? Anybody have clients that are fine? And then all of a sudden they're struggling? Okay, that is Miss Jill, and she would be a great candidate to keep going to outpatient therapy and to be able to get some extra support in IOP. Okay. Excuse me, y'all. Outpatient therapy. So obviously you guys know, this is the once a week, go talk about your mother, lay on a couch. People who are in outpatient therapy are probably pretty motivated, right? They're typically calling you. I was going to say people don't often force each other into outpatient therapy, but that is not true at all. I think spouses force each other to go to outpatient therapy. Parents drag their kids, spouses drag their spouse. People very frequently force each other to go to outpatient therapy. So there's that. But still, there's some level of motivation because obviously they don't have to. It's not prison. So people in outpatient therapy are really mostly maintaining their ADLs. They're taking a mental health day here and there, but they've kind of mostly got it together. They're doing the things, they're functioning. They probably have some kind of support system in place. They can maintain a schedule. If they can handle seeing you at 3 o'clock every Tuesday, they're rocking life. They're not missing a lot of things. And if they have to go to something, then they got it, right? Like they can go to the grocery store, they can go do the things that they need to do to function. They just kind of want to work on their junk and learn some new skills. So a lot of times people will ask, how do I talk to somebody about needing a higher level of care, right? And again, I think it can be a really hard conversation as a therapist that I want to validate, because you think, oh my gosh, they came to me thinking I could help them, right? And if I tell them I can't help you, then what does that say about me? It says nothing about you. It says that they don't know what level of care they need, and that you are being a really good clinician by being able to offer that up. So I just want to take that away, that you are doing a great job, and it doesn't mean anything about you. It just means they need a different level of care. It's no different than somebody that goes into the ophthalmologist to get their eyes checked, and turns out that they need to go to the ophthalmologist and look at a glaucoma history, and if they need eye surgery, and if they need those sorts of things, right? Like it's no different. So you want to explain your concerns, that this is what you see. You see that maybe they're not able to make the progress. They don't have a lot of support. That's always a really good one to note, because they can't take that one too personally. You want to validate the client's strengths. We always want to start with, man, you're here, right? Like that's always a great one to start with, because it's really cool that you showed up, that you actually want to work on this. And so what I've always told clients is I want to match your energy. And if you're coming to me saying that you have energy to work on this stuff, then I don't want you to burn it up coming, once or twice a week for an hour and not making the progress that you want to see. I want to maximize your motivation and energy, and I want to help you get better as fast as you can so that you can get back to life. So this is me matching your energy, which I value. Validate their struggles, that it makes sense that it's really hard for them. I love that phrase. It makes sense that. So given everything that they've been through, given their lack thereof, resources, support, et cetera, then it makes sense that they might be struggling. We want to talk in terms of gains, not costs. So this is what we expect you to get out of this. I expect, you go to this residential program, 30, 60 days, whatever, you come back to me, and I expect that you're going to be a different person. You're going to be in a different place. It's not going to be so hard for you to wake up. You're not going to want to die every day. You're not going to wonder if this can actually get better. You're going to be in a very different place. And a lot of people, most of the time, they can hear that. And that's actually kind of exciting for them, because they want to be in a different place. You want to educate them about the level of care. Again, most people only know what they see on TV, which is not always great. And you don't really see IOP on TV or like day treatment. Like, what is that? So being able to educate people, and even educating that residential is not a hospital, right? Like it's something very different. And you want to explain how this more care can help treat their symptoms. So I always start with the things that clients want to work on. So, know you're having a really hard time sleeping every night. What if you could go get, learn skills to be able to deal with your anxiety so you could sleep every night? How great would that be, right? So I think as long as you really frame it in a validating way, and in terms of what they're going to get out of it and how it could help them, then they're not going to take it as a rejection that you're saying they're too much for you, or something like that. And if you're sending them to something like IOP, then it's, hey, you're still going to keep seeing me, so I'm not even rejecting you. And if you're sending them to PHP or residential, it can be, yeah, and as soon as you get done, you're going to come right back to me. So I think that we can kind of negate a lot of their hesitations with that. So as we're looking at step down, right, from a higher level of care to a lower, we always want to do the least restrictive option. So if someone can handle outpatient therapy, we don't want them in IOP. If someone can handle IOP, we don't want them in PHP, right? We always want the least restrictive option. And so when someone graduates from one step to another, they step down. Now, what we typically see is it takes a minute for people to stabilize. And so if someone goes from a really highly structured environment like residential, and then they're in PHP and they're still there every day, and then now all of a sudden they're in IOP that's like 3 days a week, that can be very difficult for them. And so you want to make sure, first of all, that people are always doing a good step down. It's so crazy to me when I hear about people that were like inpatient, they were hospitalized for suicidality and they leave for like an outpatient therapist. That's like crazy to me. So we really want to make sure that we are giving people the proper step down so that they can be successful where they're at. And we're not just giving them an intense amount of treatment and then like kicking them out the door and there they go. So that they are able to kind of take the training wheels off easily to get down to the lowest level of care possible. So I think it's always very important to take the stair step approach and not to skip a level of care, even if you do it briefly. So if someone was in partial, then let's try to get them to do IOP for at least a couple of weeks, just to help them get their footing, so it's not such a shock to the system. So what about other alternatives to a higher level of care? What could that look like? One of the things we do a lot is, let's say someone is seeing you for EMDR therapy, you might refer them to somebody else for DBT, so that while they can really focus and just do their EMDR with you, and then they're learning DBT skills with somebody else, and you're keeping it all in the outpatient realm. Or, vice versa, they're seeing you for eating disorder work and you send them to somebody else to do EMDR so that you can focus on the eating disorder piece and somebody else can start working on the trauma piece with them. So that is definitively an alternative. Invoking group support. Sometimes somebody just needs like a little quote unquote kind of shot in the arm for stabilization. So, okay, so somebody said you can't see two therapists at the same time. That is typically, there's no rule about that. That's typically a rule or a question, like a preference for each therapist. Now, let me tell you, I would never recommend a client see two people at the same time for the same thing. Right? Like, because that just is going to get real sticky. And it's just not going to be good. They're going to split. It won't be good. But if it's extremely truncated, so when I've shared patients with people, then it has been very strictly like, let's say I'm the therapist. So I'm doing, whatever we're doing each week, we're processing, we're doing EMDR, we're doing, CPT, whatever we're doing. And then you are teaching them DBT skills. So when they come in and they want to talk to you about their marriage, nope, today we're doing the how skills and the what skills. And so as long as you, I think, can maintain good boundaries with the other therapist to keep it real firmly truncated, and it can be really helpful that way too, honestly. Like if you're trying to get through an EMDR protocol with somebody and they're coming in with like, crises, or they're wanting to talk about their marriage and they're wanting to talk about X, Y, and Z, and what do they do about college? And it's kind of this little avoidant thing. Then having them see somebody else that can deal with all of that and you can just whip through the EMDR protocol can be super, super helpful. So you can, you just need to make sure that you have really clear boundaries with it, basically, and that it's very distinctly defined what you're seeing them for. But that's a great question. So sometimes we call it like a shot in the arm stabilization. So we're not trying to go somewhere, for, maybe even a long time. Maybe they literally just need like 2 weeks of IOP. Maybe they literally just need like a couple of weeks of PHP and then they're going right back to life, right? Those things can be really helpful. So that's another thing, especially if a client's already been in a higher level of care. And then maybe they have a crisis. So you have a client who just found out her husband's cheating on her. She's already done residential. She's done the thing. She was in a better place. Now she's having like this lapse and she's really struggling. Maybe just a little brief intervention is exactly what she needs to help kind of kick her back into high gear. You can always do 2 times a week sessions. You can always add a family therapy session. Or add like yoga. We have some therapists that do yoga for trauma. We have a music therapist, we have a meditation therapist. You can add some sort of other positive coping thing on top of your therapy. And so if you don't think someone quite needs a whole other level of care, then there's lots of ways you can get really creative in the outpatient world to help them gain additional support. Any questions about any of that? Oh, there's one. All right. Oh, okay. This is a great one. So if a client definitely needs to step up, right? We've got 2 questions about insurance. I love it. So if a client definitely needs to step up, then and they don't have any resources, that's a really tough one. And I've been there before with folks, and your hands get kind of tied. I just want to validate that, first of all, that I know that feeling of being like, and you need more care. If I choose not to see you because it's not enough, then that's not helpful. So what can I do for you? There are places out there, there are very few, but like Mercy Ships is one that does free or highly discounted residential. I can tell you in our programs at Inova, we are really committed to having one pro bono person in every program at all times. And so if now sometimes there's a pretty good wait list, right, for that scholarship spot, because we can't see everybody for free. I like to eat, but so if we do have a scholarship spot open, we're more than happy to get them some support. You can look at like really discounted options. I mean, there's a few things you can do, but I'm just going to validate your hands are kind of tied if they don't have insurance. I honestly always say to people, like, if you can afford it at all, go get insurance. Because it's going to be especially if you know you're going to need a really higher level of care, then you really you're going to save a lot of money getting insurance. And what happens, here's another great question, when clients' insurance insists on ending treatment. So that definitively happens. For us having various levels of care, I definitely see that sometimes an insurance is going to kick somebody down when we highly disagree with it. So the best thing we can do is we appeal it. And then if that doesn't work, you step them down, you kind of do the best with it. And if it's been like a week and they're still struggling exactly like you knew they were going to, go back to the insurance. Hey, they're still really struggling. And this is the symptoms that they're having that meet criteria. And the insurance may still say no. If they say no, I mean, you get a little bit stuck, unfortunately. We live in a managed care world that can be difficult. But if you do step them down and they struggle, as hard as that is, then the best thing that could come from it is that they actually can go back up in care. We can definitely provide a list of those that do yoga, music, and meditation. Jana can too, and I can type these out, but just for everybody, so the whole class can have them. Jana can too does music therapy. She is amazing. Elizabeth Garrison does meditation therapy, and she is also amazing. And Jennifer Alamia does yoga, and she is amazing. So all of these folks are great resources that I encourage you to use. Jennifer has some different contact information. I'm happy to provide. Janet and Elizabeth can both be reached through the Inova main line, and they are happy to see folks. So we're being asked some questions about like low income benefits insurance. It's really going to depend. I know we have folks here from around the country. So it's going to kind of depend on your area. So I would encourage you to kind of look into resources in your area. For those in the San Antonio area, I'm happy to provide them. But it's really going to kind of depend on your area. Somebody says they have a child who is severe anxiety and depression, and the family presented to the ER, and the child was held, but then they were discharged. The best way to identify an RTC that'll work with an uncooperative client. So that's a good question. It's a 13-year-old. So unless you're in Colorado, they can force people legally into treatment. Fortunately, I don't know, depends on what side of the fence you're on. In Texas, we don't do that. We can't do that. And so that's not an option. The best thing you can do is just try to motivate them. Like we have an RTC for teens. It's called Inova Joy. If they are motivated at all, and sometimes we can help get them there, we would love to see them. And RTC, it doesn't just have to be in your city, in your state. Somebody can go to RTC around the country. So like, for example, in ours, we'll have people from New Jersey, Hawaii, New Mexico. We have people from everywhere come to our RTC in Texas. And so, that's one thing to consider. You can look anywhere. If they need a locked facility, if this is a kid that is absolutely like going to tear everything up and they're going to run and whatever, then there are some different locked facilities, but that's what you want to look for. But somebody that's just uncooperative, we had a kid go on a hunger strike for the first 3 days that he was with us, and like, he's doing great now. So if you find a place with like a really good staff that can work on those that need motivation, I mean, that's the whole point, right? Like a kid, first of all, especially if it's a boy, but a teenager at all, then you're not really expecting them to have a lot of motivation. Honestly, you're not expecting them to have a lot of ability to deal with things. And so it's really, the staff should be prepared for that. To be able to offer them support. And let's see. Okay, so a little bit kind of along these lines, talking about us. So at Inova, we do have intensive outpatient for women, men, and teens. Most of our programs are telehealth. We started telehealth before it was cool. And so we do have an in-person female and an in-person teens, but all the rest of our programs are done through telehealth. So anybody in the state can do them. All of our groups are very tailored to the symptoms of PTSD and trauma, and they kind of go right down the list of criteria. They're all empirically proven. I'm a stickler for content. So shame resilience, of course, looks at shame and how we develop it. DBT, when I first learned DBT as a graduate intern, my supervisor said, if you'll learn this, you'll use it every day. And it's so true. I do use it all the time. DBT skills are amazing. They should teach them in high school. Cognitive processing therapy, sleep and nightmares group, meditation therapy led by the amazing Elizabeth Garrison. She also does outpatient stuff. But these levels of care, if they need a therapist, they can see one of ours. Otherwise, they can keep seeing you for outpatient therapy, and they can come to one of our programs while they see you. Our women's residential, they get EMDR 3 times a week. Y'all, let me tell you, most residentials only offer individual therapy sessions once a week. And that is just absolutely tragic to me because you have a captive audience, you have somebody that's giving up, 24 hours a day, 7 days a week of their time. I just think they should get more than that. So they get 3 sessions a week with us to make rapid progress. We have a vibroacoustic therapy bed that came from Australia. It's amazing for nightmares, for anxiety, for chronic pain. We also have one in our main office. If you're in the San Antonio area, come by and check it out. It's amazing. We have a workout room. We have 24-hour nursing staff. We can do one-to-one monitoring. So if someone's suicidal, we can handle that. And then, of course, we have a psychiatrist with medication management, the amazing Dr. Tom Weiss. We love him. We have a teen residential. So it's same thing. They get 3 MDR sessions a week. Both of our residentials, or all of our residentials, are in an actual house. Different houses, of course. Our women are in a house. It has a pool. It's a beautiful house. All of the rooms in our residentials are named after survivors of trauma. And we have asked them to write a letter of encouragement that hangs framed on the wall for whoever stays in that room. And then their favorite quote hangs on the wall. And so we really want to honor survivors and people in their stories. Our teen residential, we have miniature horses. This little guy is Dusty. He's missing an eye, and he's just the cutest thing on earth. And this pig here, I believe this one is Hamlet, but the pigs are actually weirdly therapeutic. The kids like to sit and brush them, and they're just tons of fun. And so we have our teen residential as well. There's a different house for boys and a different house for girls, and never the two shall meet. We have a certified teacher on staff. We have an accredited school curriculum, and so they're getting school credit while they're there. They're getting caught up, and they're able to stay safe and work on issues. So we are really excited about Inova Joy and everything it has to offer. And here's some of our super, super fun staff. Okay, Lahua House is one of our newest offerings. It is a house in central San Antonio, and it has a house mother there. It has a pool and a movie room. It's in a cul-de-sac that backs up to a greenway, so it's really cool. And we talked about that supportive home environment. So let's say you have someone who's 19 and they're still living at home and home is not a great place for them, then Lahua House is a place they can come. They can stay. Think of like a sober living, if you've ever heard of that, but without the alcohol use addiction kind of history requirement. So they stay there. Like I said, supportive environment, fully furnished. They can stay, they pay the first month up front. After that, it's just weekly. But they can stay there while they're in therapy, and they can kind of get away and focus on their own stuff. So we are super excited. This has been a cry of my heart for about 10 years to be able to offer. Right now, this one's for women. We hope to have one for men one day, but this is definitely something that I am ridiculously excited to be able to have, because so many people just don't have positive environments to recover in. And it's so much, right, to go get an apartment and get furnished, and things are so expensive these days. So this is a resource. Please, please, please share it with your clients. We want to offer this. And here we grow again. We're so excited. We now have a Spanish IOP track. So if you have any Spanish speaking clients, or you know any Spanish speaking clients, send them to us. Right now it's for females. But again, we hope to expand that in the near future. So if you've got males, send them to us. We'll make a male track, but we do have a Spanish speaking track for females who have had trauma. Same groups as our English speaking track, a lot of the same leaders, because our leaders are really talented. And we're opening up programs in Wisconsin, Hawaii, and New Mexico. So we're going to be able to serve more states and help more people. So we're really, really excited about that. Thank you for being here. You guys are absolutely amazing. I love the questions. I love the engagement. Really appreciate you guys showing up. I don't know how you made your way here, if you got the newsletter, if you saw it on social media. You can, if you're not signed up for our newsletter, then you can go to our website, you can sign up, and you can make sure that you're able to see all our future webinars. We do this once a month, and we want to be able to offer everything that we can for you. So thank you guys. for everything, for being here. And let me know if you have any more questions. I do see, yes, this will be available to view. I don't send out slides, but you will have a recording. And so you can go back and you can watch it. Please give me like a week to be able to get you your survey and certificates. I try to be on my A game, but I'm not always the fastest about it. So just give me a little cushion. But if you haven't heard from me in a week, then please reach out and email. But I will try to get those to you as quickly as I can so that you can get your certificates. If for some reason you need yours ASAP, if you're renewing your license tomorrow, then let me know and I will make sure that you get taken care of. I don't want to leave you hanging. So thank you guys. You guys rock and keep changing the world. Take care.